Welcome everyone to our webinar event with Quality Insight. We're joined by special guests, Prestige in Home Care. So we've got Brooke and Leighton from Prestige in Home Care joining us to talk through some home care changes. So really today, or this session, is about what are these changes that have taken place from the 1st of November and how it potentially can impact around the social works teams for hospitals. Really grateful for hospital teams to join us. We've got well over 60 odd registrations that have come through. But before we kick over to Leighton, I've got a couple of housekeeping things. So welcome also to those people that are watching this post the event, so online, either via LinkedIn or YouTube later on. We also will be sharing a link to those people that have already reached out to me to say, can they watch this event post production. So yeah, you've got the ability to make some comments. There are some people that have entered the studio. They've got the ability to ask questions directly if need be. But also anyone who's watching or viewing this, you can ask questions either via LinkedIn, where we've got the lovely Lisa who's monitoring that for me, or you can ask on camera if you wish to. Leighton and Brooke, welcome to a LinkedIn Live and joining us on this webinar.
Thank you very much for having us today. We really appreciate this opportunity.
Yeah, so Leighton, we're going to talk all things post the 1st of November. And I think the first thing really to point out is the skies didn't come crashing in, although Brisbane got smashed by storms. But the sky didn't get smashed, they come in, the wheels kept turning. And more importantly, your clients, residents in aged care, they continue to get looked after. But there are some changes coming through. So, mate, what I'll do is I'll share your presentation and then you should be able to drive from there.
Wonderful. Thanks so much, Brad.
You should be good to go, Leighton.
All right. Hello, everyone. Thank you very much for having us on today. We really appreciate this opportunity to talk about the new support at home changes that came in on the 1st of November. I'm going to take you through a slide deck and we'll talk about each slide as we go through. So a little bit about us. I guess Prestige is a family-owned business. The CEO and founder, Nick McDonald, started the business 20 years ago for in-home care support. It's family-run, so his sister Thea is our COO. So we're very hands-on. We're all part of this business, and we just celebrated our 20-year anniversary this year. So a bit of background as to how we started. So Nick's mother did have early onset dementia. His father had a medical centre. Nick was a registered nurse. He started the business above his father's medical centre in Melbourne and Moorabbin on his own. And eventually he had another person support him. So right now, with our carers and nurses and also full-time staff, we have over 900 people working for the business. So we've come a long way in the last 20 years. Look, we have experience in 24/7 care and palliative care, and that's a big part of the business and referrals that we do get from our hospitals. We work very closely with hospitals. So for the last 4 months, I've just worked with social workers and discharge planners, working with clients that would like to return home with these workers and providing their support. So we can supply 24/7 care for them. We've got registered nurses that are on staff with us, and all of our carers are certified level 3, level 4, all work for Prestige. So we have extensive training in palliative care. As I mentioned, 24/7 care support, which we can do over a lot of our competitors that don't offer those services. We have specialised in dementia and also a lot of stroke victims, motor neurone disease, etc. So we're all certified level 3, level 4 carers, and our registered nurses. As I said, they're all recruited and work for us here at Prestige. It's not outsourced. So there is a lot of flexibility with our service. So we do offer a 1-hour service up to 24/7 care. So that is another good part of the business that we offer. As little as a 1-hour service, it could be just an appointment drop, going to the pharmacy, picking up medication, etc. So we're all vetted. And yeah, like I said, we're all put through our training, so we really know what to do. 24-hour on-call support is available 24 hours a day. So that's another great point that we have with Prestige. So we do have a dedicated case manager for clinical care and 24/7 care. We have a registered nurse, a case manager that goes out and has the original consultation with the client, and then works out services that they may need, works a care plan out for them, and also works with the family and the client on education they may require. So how we support the hospitals. So I guess like working closely with the hospitals, we really support the hospitals with their needs. That would be like they're turning over the beds, obviously, clearing up the beds for those clients that wish to return home. As I said before, we find our clients do much better in the comfort and the familiarity of their own home space and do recover very well. So yeah, we support all of that. Smooth transition, obviously, for that client from hospital returning back home. We also have focus on sustainable care to give patients and their families the confidence and support. Also reduced administration burden. So we do look after a lot of the administration hassles that a social work team would be working with. So yeah, we do all of that as well. So how we help patients and families. Once again, comfort and confidence. Advice on care options for the families to make informed decisions, that flexible tailored care, tailored services from nursing, personal care to dementia, palliative and post-hospital recovery, future planning, sustainable care arrangements for long-term confidence and support, and also an important one, funding guidance. So assistance to understand the funding options available, a clear quote to understand the cost of the care. So we can support with that as well with the families and the client. So the funding options, obviously at the moment we have got support at home that came in. So it was the home care packages. Support at home started on the 1st of November. The reason for the support at home and this major government reform was to shorten the waiting list. With home care packages, it was up to 18 months on the waiting list to be allocated funding. And obviously this was not suitable for a lot of people. People ended up basically dying on that waiting list. So this government reform, a lot of this is about reducing the time of that waiting list. We'd like to get it down to about 6 months if possible. We feel that it could be around that 12-month mark for at least the next 6 months. So at the moment it is around 12 to 18 months. So we also work with veterans, home care, NDIS for under 65s. We're working in that space as well. Obviously support at home and also private health. So some of the great things about the private health is that if they're not registered or they don't have support at home, then we can start the actual private health immediately. So we could have someone there the following week, would send out a case manager for the initial consultation, and then we would work from there, doing a care plan. And if the client's happy with that, we could start the actual care straight away. So the home care packages transitioned, obviously we know that. One of the major things, we'll talk about this now, is from home care packages, there were 4 levels. Now with support at home, there are up to 8 levels of funding classifications. This is to more accurately pinpoint the actual needs of the client and have the funding that they require available for them. So they'll still be assessed. They'll be assessed on all of their income and also assets that they have, but they won't be assessed on their family home. So the assessment will decide on the amount of contributions that they will make towards the services that they receive. So as I said before, the goal is to reduce that wait time from 12 plus months down to hopefully 3 to 6 months. So the current assessment wait time is around 6 months. There were 20,000 packages released for the home care package recently under pressure to the government by people that were basically waiting too long for the packages. And there'll be another 53,000 packages released over the next 6 months. So that should also help reduce the wait times. This is also an important part. These are the 3 buckets. The categories, which would be clinical, you'll note nursing, allied health supports, care management, restorative care, and nutrition. These are what the government has decided are essential, most essential. And you'll notice there's a 0% co-contribution. Now that's for everyone. So it doesn't matter if they're fully self-funded retiree, they will not be paying for those services. They'll be covered by the government. There's no co-contribution. Obviously a full pensioner, no co-contribution. Independence, which is a little contentious with the personal care. Personal care will be the showering, social support, community engagement, home modifications and assisted technology, transport and respite. The co-contribution for a full pensioner is 5%, and for a fully self-funded retiree, 50%. The most expensive bucket, everyday living, the government's decided is a little bit of a luxury: domestic assistance around the house, home maintenance and repairs, gardening and meal preparations or meal delivery. For a pensioner, 17.5% contribution, and for a self-funded retiree, up to 80% contribution. They'll pay for those services that they use. So, as well as the support at home funding model, there are now 3 extra pathways that can be applied for. So you'll notice assistive technology and home modifications. So funding of up to $15,000 per annum is available on top of the support at home. Also restorative care funding, up to $12,000 and 12 weeks care for hospital to home transition. And there's also a pathway for end of life funding, up to $25,000 over 3 months for palliative care support. That will be provided obviously immediately, end of life funding. So this is another important one. Here are the new levels, 1 to 8 levels, replacing the old 4 levels to more accurately pinpoint the funding and the care needed. So you'll notice, so number 7 would have been equivalent to a level 4 in the home care package. So there is an extra layer of funding available, up to $77,700 now with level 8 funding. So those are the new classifications, 8 levels. So the budgets will be allocated quarterly based on assessed needs. So existing home care clients will retain their current level of funding of their approved home care package until reassessed to a new classification. So once they are reassessed, they will also join the new 8 levels of funding here. So as with the current system, Services Australia will still conduct the income test and assets to determine individual amounts for client co-contributions. So co-contributions vary from 3 new categories of service. Clinical care will be fully funded, as we mentioned before. So your first one is clinical supports. Notice no one pays a co-contribution for those services, whether you're a full pensioner or a self-funded retiree who doesn't even qualify for a Commonwealth health card. Okay, so then we go to independence, which is a full pension of 5% contribution, part pensioner self-funded with a health card, up to 50% contribution, and self-funded that does not qualify for a Commonwealth health card, 50% contribution. For everyday living, full pensioner 17.5% co-contribution, part pensioner self-funded with a Commonwealth health card, up to 80% contribution, and self-funded non-qualifying for a health card holder, up to 80%, well, it will be 80% contribution. Also, I'd like to add, if you do not wish to be means tested, which it's not illegal not to be, you immediately will be paying the highest rate at 80% co-contribution. So transition from current home care package clients. So clients with a current home care package from September 12th, 2024, last year, will maintain their current level of funding unchanged and will retain their unspent funds. So a big part of the waiting list was the amount of funds in home care package that people could accrue. Some people were accruing, I've heard, even over $100,000. A lot of people, $50,000 to $60,000, were accruing these unspent funds, so they could accrue them. That will be no longer with Support at Home. Support at Home will be budgeted quarterly. They'll they'll only be able to carry over a maximum of $1,000. That would be it. So there's no more accruing. So the no worse off policy ensures that co-contributions will remain the same or lower. This is just a way to get clients registered with My Aged Care once they're on that waiting list, or they've been on that waiting list since September last year. They immediately stay in the same part in the line and just move across to supported home. So they don't lose their spot. They just move. Everyone just moves across to supported home. So this gives you a rundown on how to assess all of that. So if they don't have a home care package, they must first apply through My Aged Care. There's the details there and the phone number. If they already have a home care package, there's no immediate action is needed. Okay, so anyone pre-September the 12th, 2024, all of the money they've accrued, say if they've got 50 grand, that just moves across with them. They keep their funding, they keep the money they've saved, moves across to supported home. However, they will be paying out of that money saved for all their clinical or home modifications that they receive. So they'll need to spend the money they've already accrued first before they receive extra funding with supported home, which makes sense. So, yeah, they won't lose their funding. They will move across with their funding, but they must spend that first. So, yeah, if they're unhappy with the provider, you can speak to Prestige. We're happy to work with anyone that's not happy with their provider. As I mentioned, we do work across packages as well as private care. So we are hybrid in that form. So yeah, and if they don't have a home care package yet or supported home, they just go and apply, or we can assist them with that as well. So just a quick, easy referral steps for you, like the referral will come from a hospital, submits referral via CareBridge Connect. Prestige reviews the referral and patient information. Planning, care and funding options discussed with their family. Support plan is created. And then finally, care at home, patient discharge. Prestige provides in-home care with ongoing support. So really that is pretty much a quick wrap up of those main changes that have come in place with supported home. So yeah, we just wanted to thank you for the opportunity. I think that's pretty much my little presentation for now.
Yeah, thanks, Leighton. I think just a couple of questions for me that just come off the top of my head. Now, would it be right to assume or to inform people that the license doesn't sit with Prestige? So the package doesn't sit with Prestige, it sits with the individual. And I think that creates a fair bit of confusion. So can you just sort of talk through that for me?
Yeah, great. I'll take that one. So My Aged Care organise a single assessment through the SAS assessment team. They will give the individual client whatever level they are eligible for. And with that, the client has the ability to choose that provider. It's consumer-directed care, the model we moved to a number of years ago, and they have the opportunity to select us as a provider or to explore other options as well. And at no point do we control that package. They can leave without exit fees and change that at any point in their journey.
Yeah, great. And I think just listening to the presentation on the unspent funds up until the 12th of September 2024, would it again be a correct assumption to sort of be the social work team, once they've established that someone has a home care package and unspent funds, to let them know that they need to be spending that money before anything else? Or would that be something that needs to be advised by one of your team members or a home care package team member? How would they go about explaining that?
Yeah, I think it's a tough conversation to have. I mean, we have these conversations in and out every day, and no matter how many times you say it to a person, they definitely have their own vision of that in their head. So I think as much as a social worker or somebody working in the hospital system can do to support that is fantastic. But at the end of the day, it doesn't sit with them. It's our responsibility as a provider to ensure that they are understanding how to use that funding, what's available to them, and to make sure that they do bring those funds down. Our case managers go through a lot of training to ensure that they have the right methods to approach that. It's looking at different solutions and individualized care rather than looking at them as just somebody who's sitting there with a pile of money.
Yeah.
So we'll help them to explore that.
Yeah, I guess it'll be between us and also with the services, my aged care services, that once they're in contact with them, they'll be informed that they will be spending down on those safe funds before that they receive any of the new supported home funding.
Yeah, great. Well, thank you for that. And I'm going to switch it now over to residential aged care, and then we'll have a bit of time at the end, hopefully, for more group questions. Hopefully that's all come up on the screen. Yes, it has. So thanks to Leighton and Brooke talking about home care. I'm going to go through residential aged care now over the next 20 minutes or so. Similar to what we've seen in home care, as Leighton was talking about, all the new residential aged care fees and charges, the strengthened Care and Services Act, that's all started now, or as of the 1st of November. So we've seen aged care providers across the board, including home care providers, really scrambling to understand what these new rules are and how to apply them. And I can say just from the outset that a lot of the rules were only really updated in the last couple of weeks. And in fact, there was still more clarity being sent through on Friday, Saturday. So I think it's fair to say we've still got a few things that may not be quite set in stone. But what I'll talk to you now is mainly around where the fees and charges fit. So I'm not going to go into a lot of the strengthened care and services, but I'll touch on it. So obviously this new act replaces the 1997 Act. So it's quite old and quite timely that we'd seen a change in this. The whole auspice of it is to be simplified and more transparent in its fee framework. So as Leighton was talking about from the fees and charges in home care, residential aged care has had some changes to its structure, and the intention is for it to be quite simplified and easier for people to understand. But what is key for the residential aged care provider is that they've got to explain all these things pre-entry to the point that someone understands what they're signing up for. And that patient or incoming resident is also able to nominate an approved person to help speak on their behalf. And it doesn't necessarily need to be an EPOA. As long as they've got a nominated person that's there to help them talk through the mechanisms of coming into care, they're fully allowed for that. Very similar to home care, the government is funding all clinical care and residential aged care. So the previous means-tested care fee, which was there designed to co-contribute to care, is no longer valid for any new residents entering into care from the 1st of November this year. All existing residents that are in care are not for worse off, and they will still function under the means-tested care fee realm. There's a lot of emphasis on resident rights and informed consent, as I said before. So aged care admissions teams really need to be on task in terms of explaining what that entry looks like. Similar to home care, any resident that's on anyone that's got an approved home care package from the 12th of September 2024 are also qualified for the not worse off rule. So those aged care teams are really going to be reliant on the up-to-date letters that Services Australia have issued to the resident or the patient coming through. And one of the first questions that should be asked about an incoming resident should be, are they on a home care package and when was that approved? Because that will actually dictate what sort of fees and charges could be potentially liable for that person coming in. They also need to have systems that separate legacy and new residents. So we know there was a change pre-2014. So there are people on the pre-2014 rules. There are people on the older rules, as we call them now. So the LLLB rules. And now you've got these people that will be on the post-November 1st, 2025 rules. So the providers have had to put systems in place to make sure they can separate all those legacy consumers coming through. And the other key highlight is respite. There's not a real big change in respite as it stands at the moment, but I will go through some other bits and pieces. In terms of the fee structure, look, this is just a really quick simplification around where the fees currently sit. So basic daily fee still covers the costs of meals, laundry, cleaning, utilities. All residents pay for this fee, and it's still anchored at 85% of pension. And of course, it's indexed twice a year. So they need to make sure as providers, we're explaining to people what they're paying for and the fact that it potentially will go up twice a year. The new fee that's been introduced is the non-clinical care contribution. So this is really there to, as the federal government put it, to cover those areas of support, mobility activities, anything that's non-clinical care under their definition. This is definitely means tested. So it will typically apply for those people that fall in a higher means bracket. And they will pay up to $105 a day at this stage. It will be capped at 4 years or at $135,000, whichever comes first. This fee is also indexed. So again, aged care teams have got to explain it to people coming in that this isn't a fixed fee any longer. It will change due to means. And that's where it's really important for people to make sure they've updated their means, even once they've come into residential aged care. Accommodation still acts in the same way. It's still based on a room cost split up between RAD, DAP, or DAP. So RAD, of course, a refundable accommodation deposit, a DAP, a daily accommodation payment. So RAD paying for the room, DAP paying a rent for a room, pretty much. It's, again, means tested. It's based on what choices people want to have, but it's subject to some retention clauses, particularly for those people that pay a lump sum. So really important that that's explained to people quite clearly. And the other new fee that's come out is the hotel contribution or hoteling contribution. So that's not associated with means tested care fee. It's a supplement that was given to aged care providers a couple of years back. That's now deemed at $22.30 a day. It's for those people that have got means, they pay for it. For those people that don't have means, it is supplemented still. So a really important fee and charge for people to explain. And I suppose the big change for residential aged care providers is around additional and extra services. They are no longer valid programs for new residents coming in from the 1st of November. They now fall under the higher everyday living, and they are elective. So they can't be, you can't have it as the proviso of someone entering into care has to pay that fee. The other point to it is there's no cap on it either. So gone are the days where it's a $30 only spend. You could have residents paying more if that program allowed that, but they're certainly not obliged to take any of that up. And I'm going to explain that in a lot more detail as we go through. Couple of indexations. So non-clinical care contribution, again, capped at 4 years or at $135,000, but subject to indexation. So that $105 a day, you would expect that to go up over the years as CPI is indexed against it. RAD retention is 2% up to 5 years. Once the 5 years is done, that person would no longer have 2% of their lump sum payment taken off them, is pretty much what that is at. DAP, hoteling contribution, is also subject to indexation. So where we see it at $22.30 a day now, once indexation's applied, it might be up to $23 a day. But again, we need to have that explained to the incoming resident so they're fully informed. And then basic daily fee, obviously, still has that indexation. When we look at fees and charges, one of the most important things that we train aged care teams to do is, first of all, establish what level of means does that resident have coming in. And as Leighton explained before, that's very relevant to home care, that if you don't disclose your means, you're paying full tote. It's going to be the same in residential aged care. If you don't disclose your means at all, you'll be paying the full $22.30 for hotel contribution. You may be paying the full $105 a day for non-clinical care contribution. You probably pay the full DAP on a room for accommodation. So it's very much in line that we need to make sure that people are disclosing their means, and that we've got those letters from Services Australia. One tip for admissions teams that may slow down the admissions process, a discharge process from hospital, is admissions teams will need to understand the level of means and what fees and charges to do. Otherwise, they will have to assign the full cost to that patient coming in, which could cause quite distress, particularly if that person doesn't have any money. So it's important to make sure that Services Australia letter or the paperwork is filled in where appropriate, and the appropriate letters have come back explaining where their fees and charges are at. When we go through sales trainings for team, we break it right down and you end up with something looking like this, where everyone pays basic daily fee, hotel contribution, it's means tested. You can expect high means people to pay it. Moderate means people potentially could pay it as well. But again, it's all based on a payment scale from $1 to $22.30 a day. When we look at non-clinical care contribution, similar sort of thing, it's means tested. They can pay from $1 to $105 a day. If they're in a low means or a moderate means category, they could be fully supplemented by the government. So they're not going to have to pay that. And then when we talk about accommodation, they're either paying a RAD or a DAP or a combination, or a RAC or a DAC or a combination. Low means people have been supported by the government. So that's why it's important to ascertain where someone is at, because you don't want to have that full discussion with the low means residents, scaring them about what costs are coming out of their pocket when they've been supplemented. You'll see on the right here, I've got pretty much an X next to higher everyday living. People are not obliged to pay that. So I'm going to go through that now in a little bit more detail, because I think it's an important one for hospital teams to understand where the changes are in the Act. So higher everyday living is optional, and it's to pay for those services that are significantly better than what is already funded. So the provider can't just take a funded service and start charging extras for it. There needs to be proof and evidence that it's significantly better than what's on offer. It can't cover also things like accommodation or capital expense items. So no longer can someone pay for the privilege of accessing a certain dining room as part of their additional service program. It definitely needs to be something that's factored into a significant event or service, not a capital recovery cost. They need to be issued with a separate agreement. So there's two types of agreements. There's a standing agreement, which is your daily charge stuff, and an ad hoc agreement, which is a one-off charge with a finite period. But it's definitely a separate agreement, and that resident can't sign that agreement for those services or be badgered into signing the agreement until day one of entry. So they can't pre-sign a health agreement. They need to sign their residential aged care entry agreement pre-entry, but they don't need to sign a health agreement. In fact, if a provider is pressuring someone to sign a high everyday living agreement pre-entry, they're doing the wrong thing. So it's definitely one of those things that's a big change. There's some consumer protections around high everyday living. So there's a cooling off period of 28 days from when someone enters care. Pretty much if they've agreed to services and then they change their mind, they can remove themselves from those services and not be charged. Once they've served the cooling off period, they enter into a 28-day opt-out period. So pretty much from there, 6 months into their stay, if they're not feeling that they are getting any benefit, they can opt out of a program after 28 days. They have these rights and consumer protections all the way through. The only reason why a opt-out might be a bit longer than 28 days, if it's a vendor supplied service and that provider needs longer than 28 days to get out of it. So they need to make sure that they've explained that clearly, and they need to do that through product guides and discussions with the resident and EPOA, so they fully understand and it's transparent. A key one for hospital staff teams to also have in the back of your mind, if someone goes to hospital during their stay in Resi aged care, their additional service or their high everyday living service program is suspended whilst they're away. So they're not being charged for that. And there are other mechanisms around suspension of program that need to be taken into account. And the final bit around it, it's indexed. So people can expect their program to be indexed and potentially going up, but they're still covered under consumer protections to opt out of a program if they feel it no longer provides benefit. As I said before, there's no restriction. There's restrictions on recovering from capital expenses. You cannot charge a resident without a high everyday living agreement being signed. So they can't all of a sudden see this bill coming through, and the invoice must be itemized. So it must show what exactly that person is on a program sense. For the aged care provider, there's some good things around that, in that it should remove a lot of complaints around people not understanding what they've signed up for or not knowing what they've signed up for. They absolutely need to know what they've signed up for, and they should do prior to any charges coming through. But there's absolutely no pre-solicitation that should be taking place pre someone entering care. You would have heard of bundling. Providers are still able to bundle these services together. Then that could be an example of, we got 8 services, it's $20. The true value is $40. They can still do that. But as soon as someone opts out of one of those services, it must return to a single line item menu selected program that someone then would revert back to. So, and you certainly can't force people into bundles. And absolutely, just reiterate it again, you cannot force someone to go into a higher everyday living program as a proviso of taking up a bed. So no longer is it you pay $50 to accept that bed a day. It's totally separate, and lots of consumer protections around that. You'll actually create programs that are very good value for money for people, and they enjoy engaging in, and it lifts their well-being. For those people that are currently in care homes, the business or the industry has 12 months to transition them from their additional and extra service programs onto the new higher everyday living program. So lots of providers we're working with at the moment have transition plans started to put in place, where they'll talk to people about transitioning across over that period of time. The provider also has the right to hold people to their current agreement. So whatever they've signed up to up until the 1st of November 2026. So there is a transition period going through. Big one for social work teams. I know we're coming to the end of our 45 minutes, but security of tenure is one thing that comes up a lot when I'm talking to hospital teams. Look, not all these changes are brand new, but there's certainly some reinforcement. So permissible grounds for a provider to remove a resident are simply as I've got listed there, but just to read out a couple: if the provider cannot safely care for them without available resources. So when I think to the admissions process, when people are doing clinical reviews, they're definitely looking at that line saying, can I safely look after this person with my available resources? And they could very well be one of the reasons why some applications are rejected, because the provider doesn't want to then get to a stage where they're asking a resident to leave because they safely can't care for them with their current resource. That could be staffing, that could be equipment, could be the level of training or understanding of that particular case for that business. So it's definitely one under a clinical assessment piece that it's really relevant. Non-payment. So in the legislation, there's a specified period that a provider can go back to a resident and say, look, you haven't paid your bill, we have to ask you to leave. So that's one that potentially might become an issue in the future. I haven't seen a lot of providers get really heavy with this, but I don't think they're going to have much choice in the future. So again, making sure they've got the right level of means of that person, understanding where they're at. We don't want a situation where someone has got means non-disclosed, being charged a lot of money, potentially being evicted, and then we find out 6 months later they had no money. All we need to do is update Services Australia. So really important to make sure we're doing that. Intentional breach of safety rules. Another one where we're looking at providers that aren't accepting smokers. They've got that rule in place as a safety rule within their home. If they've got someone that's a bit suspect around, will they continue to smoke or cause an issue, they're not going to let them come into the home because they're potentially going to have to ask them to leave because they're intentionally breaching safety. It's a position that providers don't want to be in, where you're having to ask people to move out. A couple of things they have to do if they do get to that stage is they need to give written notice of 14 days, but they certainly need to give plenty of warning beforehand as well. So there's lots of onus on the provider to do that. They also need to, and I know this is not new, it should be happening pre-1st of November, but they need to also make sure that person is relocated to a place that can look after them clinically. So whether or not they engage a broker to do that service, which we've certainly been engaged in the past to do that, or they find another form of accommodation for that person, but they need to make sure it's somewhere that can clinically look after them, that's also financially appropriate. Now, I might have some people screaming at me, that's why they go back to hospital. Maybe, but the provider needs to do more work around finding appropriate care before that is an option. Lots of obligation around continual care before exit. So they can't just stop caring for that person because they've been removed from service. So they certainly need to make sure that they're keeping up with their obligation around that. And they also need to certainly notify the regulator around what these reasons are and what steps that they've taken to help mitigate that resident from having to leave service, and if they do, what steps they'd put in to take place. One final point I want to point out around security of tenure is around respite. If someone was to be taken to hospital for a night under their respite, in the past there was the potential for that person then to be discharged from service. They can't necessarily be discharged now from service. So if they come into hospital for one night of stay, they're not discharged. They've still got security of tenure rights, unless there are some other decisions being made around that. But providers certainly can't sort of park someone in a hospital, discharge them, and not bring them back from respite. So it's a really key one to look out for there. A summary of points. Look, transparency is absolutely mandatory. As I mentioned before, a resident needs to sign their agreement before coming into care, and it needs to be clearly explained to them what all the fees and charges are. We've started to do mystery shops with providers where some of those specific questions are asked of us to test is around how well did the team go through the contract? How well did they explain fees and charges? How well did they explain what someone is paying for that they're going to get and how it's going to be delivered? So there's lots of work in and around that providers have already started doing and continuing to do. Clinical care is fully funded by the government. However, non-clinical care aspects, they will co-contribute. So it's something to look out for there. I can see some questions have popped up and we'll come back to them once I finish this bit. You've got accommodation flexibility there. You still can pay a RAD DAP or a DAP, RAC DAC or DAC. We're a business full of acronyms, so I apologise for that, but we need to make sure that we're explaining these things properly. Lots of resident rights and protections in and around just the security of tenure, in and around how high everyday living fee works, in and around the obligations of the provider and reporting, all that sort of stuff. And the final bit there is individualised conversations are absolutely essential. In the sales training that we've done with a number of providers, we've done probably 300 people in the last couple of weeks, is in and around how do we have those personalised conversations that are meaningful to that individual, so we get to understand them in bringing them through admissions, but we need to understand the full aspect of them. So I can't see admissions into aged care providers being any quicker than it is now. I know it takes a bit of time. Right now, we've got lots of people sitting in hospitals waiting on clinical assessments, etc. But this process will be a little bit cumbersome when you're looking at, we need to establish the financial means of person. We need to look at the clinical aspects. Some businesses are looking at ANAC, how it fits into their funding model, and that, of course, flows onto clinical care minutes. So there's lots of stuff there for a provider to take into account as they're flowing through. I thank you, everyone, for listening through. I'm going to jump off this screen just so we can do the final wrap-up. Lisa, I did see some questions pop up there. Is there anything that I can answer?
Yeah, sure, Brad. I'll just pop some questions through. So I think the first one is for the Prestige crew around end-of-life care package.
Yes.
Yes, so the question is around the income and asset testing. So end-of-life care package is not income and asset tested. So anybody is eligible. They don't actually have to have a support at home package to be eligible for that funding. It's to top up from the federal level to ensure that people do have that availability and that capacity to actually get the care that they need when they're at the end of life stages. Obviously, there's still the state funding which supports that too, but this is additional and separate to that. So it's $25,000 available over the 12 weeks, and the person can use that up to 16 weeks as well.
Great, thank you. We've got another question from Jessie. So Brad, this one's to you. How long is the income and assets assessment expected to take, and what happens pending?
Yeah, so the Service Australia have promised that they will turn around within 28 days the income and assets forms and the decision made around that. There are some pretty good tools that you can use out there as well. So My Aged Care portal has got a calculator that can be used for the new rules as well as the old rules. But yeah, it's a good question around that. There's the promise and then there's the reality. So I've seen some of these things turn around 3 to 4 months later. the provider won't have any choice but to charge full tote, but that doesn't mean that they can't credit back money if they've overcharged. But yeah, we certainly don't want to see a situation where people are overcharged, particularly now with pressures. I mean, it's hard enough coming into care without then being charged extra for something. Yeah.
Great, thank you. And another one from Jesse, back for the Prestige crew. So given the increase in packages being released and the expectation of decreased wait times, is there a workforce to support this care?
Yeah, I think across the sector, we're seeing challenges with workforce and everybody's hearing that. And I think as well, what we try to deliver is obviously support that has, certifications that are aligned with what's being delivered as well. But I think in terms of what we're seeing, we do try to match the care workers to the client needs, which obviously does pose a bit of a challenge, but we do have capacity across the board, and we do see quick turnarounds as well. So as an example, we've had a number of 24-hour clients come through in the past week or so, and each of those we're working through on an individual basis, and we will be able to deliver that within the timeframes that the clients are needing.
Great, thank you. Another one for you guys as well. What happens if the money runs out before the 12 weeks of starting the end-of-life package?
That comes down to the provider. So the provider needs to manage that. And one of the strict guidelines around that from My Edge Care is that you do need to make sure that that money is going to last the full 12 weeks. And if there's any kind of chance around that being a longer period, so up to the 16 weeks, the provider has the responsibility to make sure that that will sustain the full longevity of that period.
Great, thank you. And another one for you guys as well from Toby. Is there a co-contribution for end-of-life care, restorative pathway and ATHM funding?
No, there's not. So this is one of the real benefits of the new system. So none of those have any contribution, which is fantastic.
Yeah.
Yeah, okay, great. And another one. So what happens if the person outlives their prognosis? Will there be further extensions on the package?
Assuming this is in regards to end of life, unfortunately, they have said that up to 16 weeks you can apply. So getting to 12 weeks, if the person is having a longer prognosis than expected, then you can apply for an extra 4 weeks of funding. But unfortunately, it isn't planned to enable any further than that. And I think this is a real barrier that we are going to see, because you never know how long a person's going to live. People get given prognosis all the time of 3 months and they end up living 6 or whatever it might be. So I think some of these findings are obviously going to be taken back the more it happens to the government, and hopefully they'll look at some improvements around that.
Yeah, and I think another thing too is we were doing a presentation this morning with St. Vincent's. With the end-of-life pathway, they don't necessarily have to already be registered for support at home. So it can still be applied for as the end-of-life palliative care. Yeah.
Great. Okay, thank you. That's fantastic. And then the last one is just a comment from Paul. Seems that the assessment of clinical and support needs will be more critical going forward. So the information available, the less time it should take. Yeah, absolutely.
Yeah, and we've seen that through CareBridge and also other work we've done with providers that they really are wanting more information so they can make a better, more informed choice. And that's not only just around the right care staff and training and all that sort of stuff. It's the right fit for their business too. So yeah, it's one of the more unfortunate changes that we've seen. But the better the quality information, the quicker the decision and turnaround can be. Yeah. Yeah. Is that all that
that's all online.
Yep.
Yeah.
Lovely. Look, I'd just like to wind up, but thank you, Brooke and Leighton, for your contribution. Thank you to all those people that have jumped on live. We've had between 30 to 45 people at any one time. For those that are listening, watching this later on, thank you very much for chiming in. Our intention is to have a webinar series that we do every month. So we're looking at the first Wednesday of every month to do these sessions. And predominantly, we want to look at really honing in on those topics that mean something to you. So if you have any suggestions or recommendations, please let us know. We will be also putting out a couple of topics out there that might even break down further what we've spoken about here, because I am positive that in the residential aged care space and home care space, we will see changes over the next 2 to 3 months, because they're just going to have to be there. So thanks again, and everyone take care and have a great day. Cheers, guys.
Thank you.